the way healthcare is changing now, it's a lot fast paced now. A lot of people wasn't going earlier to the hospital. They don't have any history on how to treat those patients. So this is really a first real generation of us going to the hospital, really treating us from all kinds of symptoms now, all the way from cancers to diabetes.
But how hard is it for a patient to get their record?
I had a son that was diagnosed with cancer in 2008 rather. He passed in 2009. The doctor said that he had a brain tumor that was inoperable. He was going to die within a year. Fortunately for us, we missed a clinical trial because we couldn't get his medical records there in time. And that impact drove me to where I didn't want another parent to have to deal with what I dealt with. So that was the journey of where Match Rite started, right? It was really to help patients unify their portals, match their records between all conglomerates. For healthcare to be successful, technology has to lead. The usability of the technology for the patient is going to be important, more important than ever before. You can't just roll a tool out and say, hey, this will use our practice. That's the reality of where things are right now. But I don't think we were prepared.
I want to talk about culture, because when it comes to healthcare, I feel like culture plays such a big aspect, but I feel like it doesn't play, or the people within healthcare, they don't really realize how much culture plays when it comes to just, like patient safety, and this is me trying to establish what exactly is the problem within the healthcare system, which there is a lot, but I want to start with culture today. What's your take on that?
Yeah, I guess a good way to dig into that is to really focus on the areas that are being served, right? Because then that's where it starts. The people that's being served go to doctors that makes the services, and then the facilities that sits above that are the one that provides the infrastructure. But then you get back to the payers of it, right? It sits above the infrastructure, and they're the one that supplies the income or who's getting paid from that standpoint. But when you think about culture, it starts at that lower level of the people that's being served. So either it's underserved areas, that's if it's rural areas, that's in the inner cities, our urban areas in the inner city, and then it's the rural areas that maybe sit out in the place where I'm from Mississippi, right? That really doesn't have a higher population.
I love Mississippi, by the way.
Do you? Right, good job.
Yeah, someone told me how to pronounce it because I could not, and they're like, just say Mississippi.
Mississippi, yeah, you can say Mississippi. As we would say back home, shout out to everybody, the SIP, right? Is what we usually call it. But so the underserved areas are in two pockets, right? Those rural areas, right, that just don't have the population, and there's a dense populated cities that can't get the resources they need as well. But I think those are the cultures. There's two separate cultures, right? But they both are being, impacted the same way.
Right. Huh. And like when you say like infrastructure, how exactly does culture play in the infrastructure? I guess healthcare in this scenario.
Yeah, because I think it's like we'll just stay on those two different, populations, so to speak. So in the urban area, you have a dense population of underserved areas that may be afraid to go to healthcare spaces, or sometimes doesn't have enough to service, those patients too. And then really training them on understanding what healthcare is, right? They may not have been to the hospital a lot. Parents didn't go to the hospital before then, our culture. And then it's passed on to the kids. And then as we get in our age, we start going to the hospital, just not as prevalent as much. But those are the dense population area. That's more in the urban areas. But you look at rural areas, they probably have the same doctor over years, right? The same doctor treated their whole family, right? But then those doctors are going away, and the resources aren't necessary there. As those doctors get older, they're not being replaced. So the rural areas are still suffering from the, just the impact of not getting as much resources as well as the urban areas. But it's two different impactful ways. One is used to having one doctor that comes to the house probably that treats your mom, your dad in the rural areas. But then in urban areas, you have this expectation that it's the grandma would say, go drink some casserole or whatever. That was your treatment, right? So they're both being impacted by lack of resources, but the culture that shines on both sides are drastically different. But the infrastructure is the same. Infrastructure impacted is kind of the same.
So where do you think that that problem started from? Especially as you explain, like the underserved communities, most people don't have access to a doctor that they've had their entire life. Yeah. But in the rural side, most people do. Yeah. Like, where do you think in the underserved community, where did that problem start? Is it like a problem with trust?
It's there's so many different ways to look at that, right? I think, trust is true, right? But I'm sectioning this out for a reason, right? Because I think this is what the reality of what our culture is, or other cultures are. But in the underserved areas, in the urban area, usually they don't trust the hospitals for sure, for whatever reasons that is. And that goes back to what I was saying before, is that our parents wasn't big to go to hospital. Most of the men, especially in our communities, necessarily weren't going to the doctors. But in the rural areas, even where I'm from, right, in Mississippi, it's a little different there because like there's one doctor that services everybody, right? So the trust factor in those rural areas are more so there because the same doctor that services my mom and dad are going to be in that space. But what happens, they're not getting replaced, right? So the resources are not getting replaced there. So the trust does exist, right? It is a factor, but it's different on both spectrums because on the urban area, you don't have doctors coming to your house. You have to go into the facility. The difference in the rural area is that doctor would come see you and the parents trust it from their own. Even the urban community or the black communities there in Mississippi where I was from, there's one doctor that you could trust, but it was that doctor. But once that doctor goes away, they're not trusting the other facilities too. So other doctors in different facilities. So and the way healthcare is changing now is that it's a lot fast paced now. It's a lot more fast paced. Either get on or get off the bus, right? So I think a lot of these facilities are having a hard time when bringing patients in and out. You know, the traffic of patients coming out is fast. But when it's fast traffic of patients coming in and out, the treatment isn't as dense or isn't as you know, prevalent as it should be for the patients that's getting treated. And a lot of times you see a patient get treated and they're coming back and forth because they don't really solve the problem for the patient when they come from that initial stance. So you look at it from a standpoint of like from patients, they're just going to get treated so they don't have to come back again. But from the facility standpoint, let's get them in out as fast as possible. If they come back, it's another pay. It's a churn, so it's just so many different spectrum, so many different things around the spectrum of healthcare, and you can never tackle them all. But just we'll get back to how I see the hierarchy of healthcare: the patients, and then from there it's the providers that provide the patients, and above that is facilities that provides the buildings, the service a patient in, and then there's the ones that payers, right, that would pay off on that. They all exist, right, but at the bottom level where the patient sit is the main source of why I built our software and why we did it that way is we knew they were the key person that has connection to all those things.
Right. And I'm going to on my way here while driving, I was listening to the radio, and then for some reason Country Wayne was talking on the radio from like an interview that he had, and then he shared about how like there are certain things in the black community that are not real. For example, hospital bills. And then he was like,
real,
if you don't catch me as I'm leaving the hospital, I'm not going to pay this bill.
It's the truest statement of how it is. And I think it's that way across the board. But I think like you go get the service, right? And our black community is always nervous to go to the hospital, right? I'm at my age now. I got in my 30s. If it wasn't for my wife, I would probably still not go, right? And I'm in the healthcare space, 100%. I don't, and some of it for me, it's not necessarily fear of going to the doctor, how they may mistreat me.
Right.
Mine is different because it's the fear of knowing that there could be something there, right? So that's a real fear, right? Just facing that fear. And in my eyes, I feel like if I don't know, I can just fight it, So there's different reasons for everybody not going. And I don't think it just sit in the black community. I think there are some fears that's there too.
Right.
But the culture, go back to the culture, is like you're going to go regardless if you're from other cultures. I was just like, I get it. I was that way too, right? And that's just kind of passed down. So I get it too, but I think it's everybody everybody has some type of fear of the doctor. If you don't, if you don't have any fears, whatever, I don't think you're living at that point, right? It's a part of it. If you go into the doctor, there's a reason you're going to see if there's something wrong, right?
Yeah. No, so like when it comes to like stereotypes like that, how much does that impact just the community in general? Since we're talking about culture and why a lot of people, community, especially underserved communities, don't, like seek care due to stereotypes.
Yes, we can go further back, right? And a lot of it's controversial, but it's true, right? Is that from our community is that there was a lot of mistreated experience that happened, right? That you can't whitewash that at all, right? It happens. We don't talk about it. It's not in history books, whatever. But the impact of that is still there, right? I talk about my father and my mother and my grandfather. They're around during the Jim Crow side and that whatever. That's not far away from where it exists. That fear does get passed on. We pretend as if it's not because we're 30 years here, but that's 30 years behind anybody else that had the trust, around the, getting the true health. They were using experiments on Black people, right? To know how to treat the other side of it, right? And that's just the reality of it, right? But those things don't go away. Those impacts in those societies don't go away. Yeah, we're past it, and we have doctors now of our own that we can match and relate to. But the impact of it doesn't go away. What's passed down, if you create a generation, right? If there's we're only 2 or 3 generations away from that, right? And every generation impacts, you know, your feasibility on how you should get treated, or your thought process on how you should get treated. And that just doesn't go away, you know. But as far as it ties to like healthcare in itself and where it's headed now, it's a huge culture shock. I can tell you this, the groups I'm working with now, because I do healthcare records, is what I focus on. Most of the research components that are working with us now are really focused on like, hey, we need to have a lot of insight on Black and brown people. We just don't, because they don't go and get treated. So a lot of the research side is trying to get at least some data on Black and brown people, because we don't go to the hospital, and furthermore, we don't share it for research either. So we can't really impact the treatment, you know, and that goes back to what I said before, that you can't whitewash what history was, right? But the treatment on it, you know, for urban and Black and brown people, not just Blacks, but, you know, Indonesians, Indians, and all that stuff that goes back, you know, they don't have a lot of studies on it, true studies on it, right? So I think they're looking for now, researchers looking for more that just to help impact, you know, society. And the baby boomers that's coming out now, it's a lot more of us that are going to the hospital now, right? Because society's changed, we're going to the hospital. The problem with that goes back to the first thing we were saying before, is that because a lot of people wasn't going earlier to the hospital, they don't have any history on how to treat those patients. So this is really a first real generation of us going to the hospital, really treating us from all kind of symptoms now, all the way from cancers to diabetes before. I'll share this story with you. When I was younger, my mom passed of cancer when I was in freshman high school. And I remember going back looking at cancer. The cancer was a big bad wolf. And in high school, I remember she was a nurse by trade. And I remember going through the books, just looking at what could I have? Because as a kid, you're always fearful, like, you know, my mom got it. It's in our family. What can I learn about it, right? So one thing I was reading on just cancers for men, whatever, one that's disseminated in men is really prostate cancer. So I came across that, and I was looking at that. As being a young man, you could imagine how fearful that was. But I was reading in the book, and it was her nursing book. It says Black men are less likely to have prostate cancer. This is 92, 93, right? Less likely. Now, what is it today? We're probably the most prominent people that have it now. But even the books at that time, it said Black men were less likely to have it. I understand 30 years later why that was, because they were never being tested. They could never track that. That's the reality of where things are right now. And that's a true story from my experience. You know how old I am too, but that was in 92, 93, right? When I saw that, and I was like, oh, well, at least that's not what I gotta worry about. I went through it all. And maybe like 2021, 22, they were talking about they're getting more research on it, on that Black men can get cancer. But you start to look at like where things are headed now. We'll kind of get back into where we're seeing more and more of us going to the hospital now. What's happening? We're getting treated, but there's no history to match that. That's what that's
new records.
With the record side of it. So you see a lot of research companies now are looking for, hey, whether you like it or not, whatever, there's a lot of, you know, Black and brown people coming in here now getting treated, whatever. We want to be able to, we can make sure we get the right treatment towards, because we're not going away. More of us are coming now, but I don't think we were prepared for some of that stuff.
And you know, I did find some stats just to kind of like, you know, like go down even deeper into the problem. You know, and these are stats by the, you know, Health Professional Shortage. It's like a nonprofit that kind of does like a bunch of, you know, like research around how many people are getting care, how many people are struggling to even get to care. And they said that in like an underserved or like urban and rural areas, you know, like a lot of patients often have to travel 30 to 50 miles just to seek like specialty care. And most people don't have resource
to travel,
or even ways to travel. So they have to wait on the bus. So they're missing their appointments. And I have an idea as to why this happened. But then that's also another stat that says almost 84 million people with limited or access to basic primary care are like struggling with just finding the right doctor, which is insane. And this is just underserved communities, not anywhere else. So Black and brown, you know, communities within the Black and brown groups. And there's a bunch of stats, but I want to get your take first as someone who decided to take this on.
So it extends, like I learned, you know, just from where I'm from, you know, the Black and brown culture, and I learned really fast that the rural is facing the same instincts of it, right? But just differently. But when you look at the Black and brown side of it, is that is that there's not a lot of resources that's there. The amount of doctors in the space is reducing anyway, right? So let's just start there, right?
Yeah.
It has nothing to do, black and brown is a part of it, right? But we are already struggling in our communities anyway. When you start reducing the shortage on doctors even more, nobody wants to go spend 4 or 5 years in a doctor's in school to become a doctor's, another 4 years in residency, whatever. It's shortcuts, right? To get there. Everybody's looking at Dr. Google now, right? And that stuff. They're going that direction.
All that
ChatGPT stuff is changing the game, right? But it's really not just. It's a reverse reaction happen, right? In parallel. So there's more people going to the doctors, right? We're proud of that. We're getting now go to the doctors. Most of our community is now going to doctors, put more trust in the doctors.
Right.
But it's at the time when doctors and facilities are reducing, the staff of doctors and nurses reducing. So you're seeing an influx trade that's running in parallel where the impact is great. And is greatly, affecting, just the culture in general. So what happens then, right? So you go to the doctor, you get treatment, they're throwing you in and out. You come in, you get in, you get treatment, they're kicking you out. Probably not fixing the problem for sure. And then on the other side of that, the whole other side of the hierarchy is the payers, right? They may not pay for some of the sub treatments that you're getting. So the facility has to make a decision on if I'm going to treat this patient, yes or no, right? The provider then has to tell the patient, say, you know what? Payer's not going to pay for this. Our facility's not going to service you here. Sorry, I can't help you, right?
Scary.
The patient is happening all day, every day. And it's going to only even be exacerbated even more. Medicare and Medicaid's throwing it down now.
Right.
So you look at the whole, where is it going? Where is healthcare going? Is it getting better or getting worse? Where I sit at it is from I always think technology can be the great equalizer. How do you fix that through technology? And one thing I looked at is how at least if the patient's getting treated, if they're getting fixed or not, or if they're going to have ongoing problems for that, at least can we document it so when they go to the next place, they can have that information. And my focus was can I unify and health record, right? So as your doctors change, facility changes, shortages happen. Whether you have to do a telehealth call in North Carolina and you're in Kansas City, or you make your way down there 4 days later, at least do you know who you are so you can get that information to wherever you're headed to? It's kind of where my focus was and where it started. And I didn't focus on that facility level, or either on the payer level. That could solve itself out. But at least could I start at that lower hierarchy where the ground level where the patients was and make sure they're informed, right? Because that's the key element. When everything goes away, doctors become shortage, facilities start to close down, payers does not pay, right? But the one person that still exists in all that space is a patient, right? So and the patient is you and I, right? So if I could figure out that problem, at least make sure that lower level's informed, as everything else at the hierarchy changed, at least that one, we have a shot, right? Yeah. There's no way to fix anything, but you want a shot, an opportunity to at least make an impact to where if there is improvements, you can be a part of that.
Right. Wow. Well, I mean, even to your point about, doctors leaving, healthcare workers, I think by 2027, I remember a stat that I read, it says almost 800,000 healthcare workers are expected to leave.
Yes.
Which is insane. So to your point with, we on the underserved groups already struggling. So imagining doctors leaving at such a high rate and how much that would impact just the community as a whole.
There's a reverse in parallel, right? More people are going, less providers there, right? So you got to create technology and tools. And technology in healthcare is going to be, in order for it to survive and for healthcare to be successful, technology has to lead, right? But it has to lead on the core surface level of the patient side, right? Or just the usability of the technology for the patient is going to be more important than ever before. Indeed. You can't just roll a tool out and say, hey, this is what we use our practice. Right. And a patient's like, well, I can't read my data. When you shared it to me, I didn't get the information. Right. The patient are going to have to be more in the center of that now. More tools you're going to see go direct towards the patient.
Right. So how hard is it for a patient to get their records? Because I know getting your health records is actually free. You can get your own records. Yeah. But I know there's so many barriers so that major hospitals can't just do it themselves and charge you whatever they charge. Yeah. But how hard it is today for a patient to, for example, if I want to just get my record, how much loops do I have to jump?
Yeah, what's the level of effort? Right, level of effort. Yeah. It depends on the facility, right? And it depends on the facility on the process. So let's break it down in two folds, right? There's a procedural way of getting your records. That's barriers there. And there's a technical side of that, right? And some of them have both, right? But so procedurally, right? So some of the hospitals, they might not have the technology to get you your records fast, but they do have a procedure where call me, it take me 2 weeks to get it to you, but we'll get your information to you, right? And then there's the other side, but they don't have the technology component wanted to send it to you right now, they have to be mailed or emailed, and they have to go through barriers to get it. But then there's the technology side of that where larger barriers are there. A lot of your larger systems, like you look at Epic and Cerner and Oracle that's based here, they have portals that exist, right, with limited information. But Epic and Cerner doesn't cross paths, right? They don't.
So there's no continuum of care.
There's no continuum of care.
That's crazy.
Yeah, because you think about it, so here in Kansas City, right? There's St. Louis that's using Epic. There's Truman University Health, I think now, that uses Cerner, right? Children's Mercy uses Cerner, and they're all trying to figure out, how to get records transferred back and forth. But St. Luke's does not easily communicate with Children's Mercy.
Wow.
Now, how many patients for let's say Children's Mercy that transfer patients back and forth? Yeah, they've tried to build these healthcare information exchange, and the government programs are really been helping to at least remove some of those barriers. Right. But they're limited with hospitals that would opt in and be part of it, right? And what do you think is happening now that government funding is going away?
Yeah, it's going
to get worse, right?
Wow.
So technology is going to have to, companies like ourselves are going to have to step up, right? That where the government gets left behind somewhat, you're going to have private companies that kind of step up and help out. Yeah.
Wow. That's wild. But thanks for doing that, by the way.
Yeah.
I do want to talk about Match Rite Care. Like, what exactly is it? And what can people learn from, like, what you provide as a solution?
Yeah, so I always go back to the backstory. I had a son that was diagnosed with cancer in 2008 rather. He passed in 2009. But at his diagnosis, the doctor said that he had a brain tumor that was inoperable, right? And he was going to die within a year. Within that time frame, unfortunately for us, we missed a clinical trial because we couldn't get his medical records there in time. And this is back when there wasn't no Dropbox, no OneDrive or any of that stuff. It was a disk that you had to mail and get it there, right? So unfortunately, we missed that clinical trial. Looking back on that, it wouldn't have made a lot of difference for what he had, right? It was inoperable. But for us, what I always say is that as a dad with a 5-year-old that's battling for his life, is that it was an opportunity for him to go on what we call a vacation, right? Just to get him out there, just so he can get out there and see something different, because we couldn't just travel anywhere because we could get treatment, but we missed that opportunity. So it wasn't the idea of the records and not getting a trial that hurt me as much, but it was an opportunity that I didn't get a chance to get him out and take him on his vacation, because I had to go look him in the face like, we're not going to be able to go, buddy, but we'll do this instead, right. And that impact drove me to where I didn't want another parent to have to deal with what I dealt with, in that case. And I understood at that point, I started to understand what the hierarchy was. It's a patient, it's a provider that sits on top of that, the facility that the provider works in, and then it's the payers that approve it, right, that pay it. And at that point, I made a commitment. I would start working for a healthcare company later, and I started to understand where the power of the unified portal would be beneficial, but it had to be, that solution had to be at the patient's level. So when after we lost CJ, it was one of the things, that was my son. After we lost CJ, I would go into the healthcare space and kind of see where the barriers were, not just from a patient, but even from the provider. Those two bottom levels of this whole Chris's hierarchy of needs, I guess. But those bottom two levels are the two that are married to solve this solution, right? So I want to make sure that not only the patients can travel between every hospital, Truman and St. Luke, but not depend on Truman and St. Luke to communicate with each other. Should you be the middleman, the bridge to move the information back and forth? So that was the journey of where Match Rite started, right? It was really to help patients kind of unify their portals, match their records between all conglomerates. And I don't care if you were in St. Louis, Kansas City, if you had records of VA, it was my goal to have the longitudinal connection across all healthcare systems. So today we connect with 17 of the top EMRs, including the VA now. We allow patients to tap into their records, their portals, pull their records in and unify. And what's done with that is unique, because now the patient has all information in one spot. Now the AI tools can make sense. Now you put AI tool and discovery tools for the patient on a patient level. So when they go to the doctors, say they're moving from Truman and saying they got records at Truman and Children's Mercy, but they got to go to St. Jude's or whatever, right? They use a different system. That parent can travel in their car with the patient, have those records in hand, and know ahead of time, all right, this is what we've dealt with. And then I think the future of healthcare change is going back to where providers are going away. Like it or not, AI is going to be here to stay. But a lot of times providers in the office are really just trying to understand who that patient is, right? That first part of your admission is a doctor trying to understand who you are. One, by either just trying to view your records, talking to loved ones or before you or looking at medical history, all that stuff. There's a lot of work that the providers are doing in that space to understand who you are. But if you can take all those records and put them in a tool, right, just in one spot, then you can start running your learning, your language across that and start to understand before you get to that doctor, have at least a bear of that summary in hand to where it makes it easier for that provider to get to the core tax of what you're trying to get to is like, how do I treat you, right? So in order for that to happen, you got to understand who that patient is. And to understand who that patient is, you have to have the information. So for us in Match Rite, it was like, can we create this unified platform that really helps the patient now unify those records to start the conversation.
Right.
So Match Rite is not the solution to say that we built this tool, so now you have all your answers. Match Rite's the foundation to get you to where you can build on top of it, start targeting those answers.
I just want to say thank you for even saying his name, because I think that's very important, and it also ties to just your core belief as to how genuine you are and what you are building. And I was going to ask, why are you doing this? Because it's such a hard industry, medical records. There's so many massive companies out there that are already building, but they are all siloed. And you're like, no, I'm going to make sure that there's continuum of care, access to records. And again, thank you for sharing your story. But on a macro level, I know how exhausting it is to work in healthcare. I have, and I was like, I'm going to do a podcast and talk about it instead. And you were like, no, I went through all of this, and I somehow figured out how to get out of it and heal from it. And it seems like you have a great support, your team, your wife, people around you. But why do you keep going till today and wanting to build this thing and open it for other industries to tap into it?
So there's just the personal side of it and the professional side of it, right? But the personal side of it, just those of you that have kids, understand kids, is your job is to protect them at all costs, right? No matter what happens, they can run to you and say, Daddy, this hurt, whatever. Who did it? I'm going to go, I'll handle it, son, whatever. Or if you tell them, you got to toughen up and get stronger, right? But you invest everything in in those kids that you want them to survive when you're not there, right? So what happens when you lose a kid, right? There is nothing to invest in physically, right? But the biggest thing I see with investing in kids and keep it is my son CJ is really keeping his memory alive, right? Because that's just as important, because that's what I'm invested in now, is to tell his story. The idea when I watched him go from walking to crawling, right? When I watched him fight just to eat his food, right, and swallowing just to breathe, I watched him go through that. Yes, it wasn't him running a touchdown, it wasn't him winning a championship, but the same drive and fight that you see in those kids, whatever, I seen it in CJ, and it made me a better dad, a better person, So the personal side of it, Match Rite, can get caught up to where, we went to not where the revenue was, but to where the value was, because that's what drove it, right? But then when you started getting the business side of it, the last 4 or 5 years, you have to understand the business, and I watched how business is a contact sport, 100%, right? So you're going to take shots, but you have to learn to give them too.
Right.
When your why is so strong, to where you're focused on just to make sure something is the growth is prominent and the connections that you're making is impactful, and not really looking at the revenue side. That's not really a good business model either, right? So I had to grow and learn how to balance both of those, right? And that's where the team comes in around you. They can pull the reins on, like, Chris, it's too personal at this point, but business, we're going to have to fight this battle. We're going to have to take care of this, make sure these components are in place. And I'm just, in no business, and I talk about the journey, right? No business gets started is 100% accurate at all, right? You're batting 60%, you're batting 60% sometimes you get an 80%, but most of the time you're probably below 50, right, that you're batting, but it's the courage to keep going on. So the why is so strong because you got to keep that courage in place to keep it going on.
Yeah.
So a lot of times, when you're fighting for, just at least, the opportunity for the business to be successful, you're going through this journey, right? And the journey changes and it shifts. And along the journey, there's stop signs, go signs. You get signage on how you should approach certain things, and you learn. And you just know the next time you run into those turns and those U-turns and those corner turns, whatever, you know how to approach it, right? Based on your experience. So I think for me, you go in there with an idea. But man, once you start jumping in this space, stuff starts changing fast for you. But it's the people that you have around you, right? Just know going into it as a contact sport. But when things get tough and hard, I tell people a lot of times, for me, my why is what kept me there, right? And so it balanced out too. So sometimes they tell you like you're too personally involved, whatever. But if you're building something that's innovative or different, you better have a personal connection to it, because you're gonna run and squeal pretty fast, you know?
Right. Yeah, I do like that you like explained it on the personal level first, and then on like the business level, and actually identify those two areas. Because I know, especially like most founders, we tend to find ourselves more on the personal level, and we get lost in there. Yeah. And it doesn't matter, how great of an idea it's sometimes the personal, if you don't balance it well with the business side, sometimes we can easily just be like, all right, you know what, this is too much. Yeah. I'm going to exit. So thanks for sticking around.
I think that there's a difference between a founder and entrepreneur. I heard somebody speak on that, but in context, he was saying something to where a founder, an entrepreneur is going to work their way out and get everybody, has that drive, right? I feel like I was an entrepreneur back in high school or junior high when I was selling now laters to my friend, candy to my friends back then. So that drive of entrepreneur is there. But a founder's a little different, right? A founder has to innovate and go spaces nobody else would go. They have to have a true... Entrepreneurs have a vision for sure, but a founder has to have a true visionary, because they're founding something that necessarily doesn't have legs and skills to it yet, right? So you have to build around that. And I think, founders have a different little press, right? Because you got to be a little tough skinned, but you also got to be able to run this thing alone at times, right?
I hear you. Yeah, I've been there, and it's very lonely. So, but I do want to ask you kind of like a final question as we wrap here. What gives you hope in your industry, mainly healthcare, and then also just in the records space? Like, what gives you hope right now, knowing that all the work that I'm doing is going to, help maybe one or two parents make sure that they don't have to go through what you went through, and you and your wife?
Yeah, I think, building a network, right? I think because we just talked about going at it alone, right? But when you start getting in the industry, start talking, the network of people that have the same passion and same connection as you, and I can see over the last 6 or 7 years that we've been at this, is that the network of community we've built worldwide, whatever, is where my hope lies, right? Because it's not just me fighting. I am working with a company, we'll make an announcement here soon, but a couple companies I work with now, but that they've been at it 6 years on another part of it, right? Connected, doing stuff in Africa in that space too, and the UK. And I was just like, well, you guys have the same drive I have, and we just start connecting, and it looks like I realized that, dang, I'm not out here by myself. I'm not crazy, right? But that's where the hope is lying, that there's people like you, the people like you that's trying to do the similar things. And just remember, man, the world is such a small space now.
Right.
It's got smaller and smaller through technology every time. And I tapped into that, right? Because sometimes we get in our little community and our little blinders on and just focus in that space, and it seems like all is lost. But man, when you step outside and you start to really look at it, you're like, there's more people that are saying yay than nay, right? And that's what you need. I think that's where the hope lies for me, is just the people, right, in the network.
Wow. Well, it sounds like you found your community, because I know that's the biggest killer of dreams, if you don't find other people doing what you're doing, because now you're thinking, am I crazy? And especially if you don't have people around you that are like saying, just helping you, just have like a peace of mind in order to keep going. So I'm glad that you find that community, because I believe what you're doing is so needed right now. And I've been in the healthcare space, and like records, even my own mom has a kidney, that problem. So I've always worked with doctors, and I've always trying to figure out whatever hospital she goes to, let's make sure she gets all of the records, so that we don't. Number one, is costly. It's very expensive to go to one hospital to another. So you are definitely creating a lot of impact for a lot of families. As we close out, is there any message that you want to share? I mean, maybe you have a new launch coming up, or something that you will love for people to hear? Yeah, so I don't want to be too precautious. Maybe by the time this comes out, we'll make the announcements. But we're working with a group now to really help patients incentivize their data, right, and really patient focus, right? It's not only able to access and aggregate your data, but having you be able to choose where that data goes to research and company and space. So we've been working really heavy on that space. I'm excited for that to come out, because it allows me, you and I, right, if we want to commit our information to the space we want to commit it to, research or cancer and all that stuff, we can start to do that on and know that data is secure. So we've been working with a company, and I hope I'm not being too premature on that, but that we can do this worldwide, right? So we're really excited about where that's headed. That's incredible.
Yeah.
Well, thank you so much for coming into there. I'm sure I'm definitely going to have you back again just to keep talking more.
Yeah.
Because this has been a very refreshing conversation.
Yeah, good deal, man.
But yeah, thank you so much for coming in today.
Appreciate it. Thanks for having me, brother.